Thank you for joining us. This is episode 112. I know we took the week off last week because of Christmas, but we are back and we're ending the year very strong with a great guest. But before I do that, I want to remind you about our sponsor, the Professional Botanicals, which is the vitamins that I take, and I've been taking them for a few months. I started taking them on the air to prove to you if they work or not, and they did work for me. So uh, my blood pressure now is down, which is I didn't believe him at first, but it is, and my what do you call it? My inflammations are much less than before. So I like him. They work for me. That doesn't mean they might or might not work for you. But here's what the doctor says.
Whether it's
Let's
physical activity, obesity, diet, smoking, low on hormones, stress, sleep disorders, or your age can be supported by reducing inflammation and aiding the body to heal itself appropriately. A stem cell is a cell waiting to be told what it needs to be. If there is inflammation, that inflammation needs to be stopped. High blood pressure, high cholesterol, kidney disease, various types of cancer, depression, Alzheimer's disease, autoimmune disorders, osteoporosis, even fatty liver are chronic signs of inflammation and can be aided by supporting the body's ability to protect those cells that it needs, removing the inflammation. And that is the purpose of ImmuStem and AdaptoStem together, supporting the body to be the best it can be.
All right, guys. The Laughter for All podcast. Most of the year we get comedians, and then we get actors, and we get models, and we get physicians, and all that. But the goal of the Laughter for All podcast is to bring people that can help you, that can encourage you, that can give you some wisdom. And a few months ago, I was flying back from Colorado, and we were on this small plane in a rainy day, getting to Denver, and I sat next to this young lady, and my goal was to share Jesus with her because that's what I do every time I'm on the plane. But she was so intriguing. She's a physician, hematologist, an oncologist, and I was and you know how much I love to learn from physicians because they have so much knowledge. And she was just pouring into me. And then we talked about her as a mother, as a wife, as a physician, and come to know she believes in Jesus Christ, and you know how difficult that is for some scientists and physicians. But she is Dr. Kim McGregor. She is the director of clinical development at Foundation Medicine, and she received a medical degree from the University of California, Santa Barbara. She's a board certified in medical oncology and hematology, and currently she is the vice president of medical affairs at Oncocyte. So please welcome with me from all the way from Grand Junction, Colorado, Dr. Kim McGregor. How are you?
Great, thanks. Thanks for having me.
Thank you so much for being on the show with us. And I have, what is Oncocyte, the company that you're the vice president now? What do they do?
Yeah, so molecular diagnostics, looking for targeted therapy. So personalized medicine is the buzzword that most people are familiar with, but really trying to design better treatments for patient-specific tumors. So very much in that, where medicine's going in terms of oncology, finding out what drives the tumor and attacking that rather than just delivering the same treatment to everybody.
Wonderful. So we'll get to those things later. But you went to Santa Barbara. Then you went to Boston. You're in Colorado now. You were in Irvine. Where were you born?
So I was born in Arizona. Well, sorry, I was born in Michigan, but I moved to Arizona when I was quite young. So my whole childhood memory from being 3 years old until I went to college was in Mesa, Arizona.
Did you want it to become a physician?
So in fourth grade, I knew I wanted to be a scientist. I was very interested in science. And I had a great fourth grade teacher who was a great science teacher. And my father was a physician, my grandfather, my great grandfather. And they didn't encourage that. They didn't really want to push their kids into following that. So it was more a scientific role. And then as, I went along through school, physician, going to medical school became not my first choice, but, down the path, that's what I ended up doing.
Now, looking back at this, all these years of traveling and doing this, if one of your daughters said, "I want to be a physician," would you encourage her?
So they both look at me and say, I never want to do this. And they both want to be veterinarians, which is just the age appropriate 10 and 11-year-old daughters that love animals, right? So, I think that they see the struggles that, they see their mom gone, they see their mom and dad working, they see us working holidays and weekends. So they do see that as a challenge. And I kind of felt the same way, with my dad being gone all the time but they also see the positive things that we're really helping people, and in their minds they see that doctor role as being someone that's really giving back to community and being a role model and being selfless about what the parts of the job that they see you know why it's attractive, why it's the right thing to do, and I think they're, as much as they don't like me to be gone and us to be working, I think they understand the sacrifice and why it's important.
Now, what do you call it? Did your mother, was she happy with you being a physician, or she's like, "Oh no, I just wanted to be a family"?
Yeah, no,
um,
it's hard to know. I went when I graduated from undergraduates, from UCSB. Had just turned 20. I was very young, and so I applied to medical school thinking I could just get in because I had good grades, good GPA. But it wasn't that easy. I didn't do as well as my standardized tests. I also hadn't done like a lot of experience. I was mainly working full time to pay for college, and GPAs and high scores don't get you in. So you have to have a lot of be more well-rounded. So it took 4 years off. And I think part of them was like, okay, that's great. She's going to do something else. And I did get into a master's program. And what it boiled down to is the master's program would be limited to what I could do. And the tuition was the same, or if not more, than medical school at that point. So I actually just said, I'm going to do the rational thing, and I'm going to go to medical school, and pulled out of the master's program, which was in genetics and research, which is really kind of what I do in medicine, and very nice. Yeah. So I think they were hoping maybe I would do something different, but they supported me, but didn't pressure me to do what I ultimately ended up doing.
did you say you have to work full time to pay for school?
Yeah. So I did. I had a scholarship out of high school, graduating when I was 15. I got my license
Wow.
August 3rd. The first place I drove was to college, which was about 2 hours away. So that was an interesting dynamic. Everyone else was turning 18, and I was just turned 16. People were turning 21. I was just turning 18. So I was always many years younger with an August birthday and had skipped a couple grades.
Right.
So yeah, I mean, I think it was this idea of what.
But dad didn't pay. Dad, the physician, didn't pay for your school.
So my dad and mom got divorced when I was in fourth grade, and
Oh, I'm
so yeah,
sorry.
no,
I'm
but it was my dad might have paid if I asked him, but he wasn't involved during that time, and we had some pride, so I had a scholarship and I was going to do it my way. And then when I went to medical school, I started working when I was 13 years old. Always worked, always had a job. And I think that gave me a good work ethic, which continues. And I will never regret that. Right. So when my dad left, my mom had prepared us that we were poor people now and we had no money. Like this
Oh,
kind of idea that, more along like, let's be responsible with money just in case, right? Because she had stopped working to raise kids, and now she had 3 kids. And so she thought she was going to, eventually. So it was more, I think the way my parents raised us was a good way that, no matter how much money they had, we didn't think that they had a ton of money and that they could buy anything we wanted. And we all worked. I was way cooler than my sister because I worked at a Chinese buffet and she had to work at Burger King. And so I didn't have to wear a uniform and she did. So I thought I was like had the most prestigious job, although I stunk more than she did because Chinese food does have an odor. So, but we all worked from young age. And I think my parents, despite having money, they really instilled in us that money doesn't, it's not handed over. And that's been a valuable lesson, right? And so I think the other thing I think is when you pay for your own education, you're more invested, which I think is important,
Mm,
right? So did I have a place to live? Yes. Could I get support? Yes. But I did pay off, um, my tuition. And when you grow up in Arizona, everyone wants to move to California. This is what everyone in Arizona wants to do. And so my deal was that I would go to college for free for 2 years on a scholarship as long as I could move to California for the last 2 years. And that's exactly what I did. I went to UCSB, and that was my goal, to go to UC school.
that's amazing. You're amazing. What's your IQ? I mean, you graduated at 15.
Yeah.
What's your IQ?
I don't even honestly remember. I think my parents could probably tell you that. But I was in the gifted program as a young child. My parents were both smart. It is what it is. But I remember when I got to the UC system, I was used to I had a 4.8, like with AP classes. I was used to being the smartest, kid in the class. And when I got to the UC system, I realized, oh my gosh, I'm not the smartest kid in the class. And I really had to start working, and I had to get my bottom in gear to even get the C plus, because everything was a curve. So it kind of does depend on where where you grow up and what, who you're in school with. Right. But it
Right.
didn't matter. I just knew that I wanted to do well, and it was easier. But I remember when I got to UCSB and I called my friends, I'm like, did we used to study? I don't remember studying like this. Like, this is a whole new world. And it instead of being discouraged, it just made me work harder, because I definitely was not the smartest kid in the class. But I grew up in this way that I was always kind of above my peers, just because my mom was a school teacher before she started being a mother, and she kind of pushed school on us. And I was also an August birthday, so I was always the youngest. And I think the most interesting thing is I grew up in Mesa, Arizona, and this will maybe play into the religion thing, but it's a very LDS, Latter-day Saints community. And all of my friends were Mormon, and they all had to go to seminary. Well, I wasn't Mormon, so I had to go to seminary. So I took an extra credit. So oddly, I just ended up having all these extra credits. And so at the end of the day, it was almost time for me to graduate. My mom just said, you might as well just start college a year early. So I skipped my senior year.
Wow.
That's
Wow.
how I ended up going on the accelerated, very, very unusual accelerated program.
That's amazing. I wish our young kids right now will do that, like get a job, pay for education. They're just like, they don't even want to get a job. So you're just an encouragement. And it's just amazing. Now, why did you pick? You have double degree, like hematology and oncology. How many different fields did you you
Yeah.
did
So
double measures?
to specialize, you have to go through some sort of, internal medicine or some basic, general residency. So internal medicine was a pathway to get to hematology and oncology. And so when you write why I want to be an internal medicine resident, I just said, I need to do this to get to hematology and oncology. And I was very interested in genetics. I worked before genetics was important in cancer, because no one really understood it back then. We hadn't sequenced the genome. No one knew what everything meant. I was working with kids with rare genetic disorders and trying to find research labs that would define what gene was the cause of this rare genetic disorder. And I used to do NICU or NICU consults and look at babies that were born with kind of funny looking, funny features and had syndromes. And we would actually do reverse genetics and try to find out what was causing that. So I was in that, in the genetic space before it was part of oncology. And as I went through my training, I thought I was going to be a pediatric medical geneticist, which is such a small, specialized world. And I didn't want to live in a big city like LA. And that's where I worked for a while. So I thought, how do I put science together with care of patients that are, going through tough stuff? I think I've always been drawn to kids. I work with kids with special needs. Oncology patients have very tough challenges. I've always been that kind of like wanting that challenge and wanting to help patients through that. And early in my academic career, I took care of pancreatic cancer patients. That was my specialty, which is a devastating disease. It was a very poor survival. And a lot of people would just be depressed. And I thought, gosh, if I can just give them some
Mm.
control over the end of their life, which is usually what would happen with my patients, then I felt okay with that. I really did feel fulfilled, where other people would have, a lot of other people said, oh, this is, really sad. Why do you want to do
Yeah.
this? And, I think that's one of the things that not everyone can do and not everyone wants to do, but there are people, kind of like me, that feels like these people are going to be going through this anyway. Anything I can do to make them feel more empowered and at peace and have control is why I'm here. And that was a really important part of my, part of my training. I learned a lot dealing with people that were, terminally ill. And I had a lot of patients that didn't live more than, 3 to 6 months. That was my patient population for a couple of years.
And you didn't bring that home with you. You didn't become depressed
No,
or
I didn't, because like I said, when there's, and I think everyone knows there's a lot of stuff in the world that's not great, and to 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 be part of it. I mean, I don't know. It's you feel like you're doing something. I mean, it's not good no matter what, but to pretend it doesn't exist isn't going to help anyone. So I'm very comfortable with that stuff. Yes, I would be sad. Yes, I would cry when patients died, but it wasn't like I didn't bring it home. I felt good about just being there for them, even if the outcome was not what anyone wanted. Right. And so,
Eh, yeah. So what's the difference between hematology and oncology? They're both blood, right? Working with the blood.
yeah, so oncology is a 2-year fellowship after internal medicine, where it's really cancers, malignant cancers, and hematology. You can deal with both heme cancers like leukemia, lymphoma, but you also deal with things like blood clotting disorders and bleeding disorders and with things like hemophilia. So it's a little bit different. And you end up doing that extra year and getting board certified in both, so you can work, but the majority of the practices are more oncology focused, just because that's what is out there. The hematology, which is that's another way to specialize in blood disorders and blood cancers. Yeah, so
Let me ask you a serious question. Do vampires exist?
so
They-
I cannot claim that I have any proof that vampires exist.
let,
So
let me, some of my fans are asking questions. It's up to you. You can ask. As Larkin asks, what causes endometrial cancer? Endometrial cancer?
yeah, so endometrial or uterine cancer, there's a couple things that can cause that. So sometimes there can be an excessive amount of estrogen that can create some, proliferation or thickening of the lining, and that can unopposed, those cells that are rapidly dividing can make a mistake and become bad players and start being invasive. There's also loss of function in some DNA repair proteins that is called microsatellite instability, where a DNA protein has a mutation or gets turned off, and then there's mistakes that are made in the cells, and those cells become, dominant, proliferative, invasive, and such. So those are the two more common causes. But and again, sometimes it's just a cell that's dividing that makes a mistake, and that mistake picks up an advantage to be immortal. It just keeps growing. It doesn't die like a normal cell will, and then it can have it pick up some properties of invasion and go that way.
Somebody asked Timothy, does low WBC count mean possibility, mean cancer?
There are a ton of reasons why people can have a low WBC count. A lot of it depends on, that patient's age. Is it sporadic? Is it post-infection? Is it, are they on certain medications? So as a single event, it could mean nothing at all. And if it's something that's persistent or it's associated with other things, and really as a hematologist, we look under the microscope, we look at the shape of the cells, we look at other features. They can be normal and low in number. The absolute number is really kind of a population where 95% of the population fits in, right? So you could be on either end of that, or you have a little bit higher than normal or a little bit lower, and it can be totally normal. And the timing of when it's drawn is also pretty impactful.
Now, how do you know? Like, let's say I go to my, I go to my primary care physician, and before I go see him, he asks for a blood test, and he looks and he goes, "Yeah, your glucose is good, your this is good." Can he find out if I have cancer or not just from looking at a regular blood test, or there's special things they need to do, other tests?
Yeah, there's additional testing. I mean, there's screening tests for the more common cancers like prostate cancer. We have a PSA. For breast cancer, we have mammograms. There's all different types of tests. With the newer molecular technology, there are some like whole, all cancer screening tests like that are offered. They can have some false positives, which can cause a lot of anxiety. They can also have some false negatives. So they're not perfect, but that's certainly where the field is going, right? So once those sort of tests become more mainstream, people are going to be offered that, looking for, very sensitive tests. It's kind of like colon cancer used to have to drink the bowel prep and then go get scoped. Now there's a fecal or poop DNA test that is pretty sensitive in terms of detecting, even early cancer. So there are some opportunities to have blood tests, but what they traditionally check with your just a regular blood count and chemistry panels aren't cancer screens per se. And a lot of times people can have cancer and have totally normal blood tests. So you have to have a blood test specific for cancer screening if that's what your doctor is looking at. And some doctors do the age appropriate.
But if they just look at a regular test, just the basic one, can they tell if like your white cells are higher than normal, or there's something wrong?
I mean, if there was something really wrong, yes, that can be a big sign, but sometimes it can be low level, low grade, and so, but as things progress, sometimes especially if it's a blood cancer, you're going to start to see things in the blood tests, but not always, right? So it can be a little tricky. When people come in with full blown leukemia, it's very obvious, right? But that's more advanced. And so it wouldn't be
Yeah.
you just coming in for your routine care checkup.
Yeah, you know what? I'm still a comedian and can't get this off my head.
Mhm.
Just the fact, like with all the technology, for someone to have to mail their like poop sample in the mail, it's just horrible. Like NASA made it to Mars, and we still have to do a prostate this that way, or do send those, you know. Like the feces results in the mail and all that. Is there new technology that without the doctor embarrassing us, man?
Well, yes, that's less invasive than the things that, happen. And so I think they're all complementary. No test is perfect. And I think the idea is when you have a test that's very, very sensitive, it runs the risk of having some false positives, right? And so it's a balance. And I mean, this was happened with prostate cancer. They said, well, we're overdiagnosing people. People would never die from this. They're dying from something else. They're dying with prostate cancer. Let's pull it all back. And what happened with that was, unfortunately, all the screening kind of went away. They said we're overtreating, overdiagnosing, let the men have their normal lives, right? But then with that big pullback, then a couple of years later, we started to see, oh no, that was too much pullback. Now we're seeing people presenting with advanced cancer. So it's a balance, right? There are a lot of people that will die of 10 other things before a cancer that was never diagnosed. And the other thing is the lead time, right? So this is something that we struggle with too. And it's a bad analogy, but if a train is coming, you don't want to be tied to the railroad tracks, right? You don't always need to see things that are coming. If they're going to come 3 years later and your outcome will be the same, it may not benefit you to, live if the outcome is going to be the same. So the idea is, if you're going to detect things earlier, you need to have a therapy or a plan that's going to make it be beneficial to detect things earlier. A lot of times when people have cancer and it's early stage and it's removed, they live in fear that when is it going to come back? Is it going to come back? And there's a lot of unknowns there, and that's a lot of anxiety, right? And so the more tests we do, we used to call them like scan anxiety, right? You come in your 1 year scan, is it back? And people would, it's a lot of anxiety. So if you have more tests with false positives and really sensitive stuff, you're going to run into that more and more. Outside of, costs, it does impact patients' life. They feel like they're constantly being just waiting for the other shoe to drop. They are very anxious. Some of them rather just just go live their lives and
Yeah.
have their faith and just say, if it's coming back, it's coming back. I'm not going to worry about it.
Right. Larkin asks, what is the main causes of cancer other than smoking?
Yeah, I think there's a lot of it can be, I mean, the different cancer types have different causes. So obviously, UV sunlight can cause skin cancer. I mean, breast cancer is just normal because your breast cells are rapidly dividing. There's things, every cancer has a potential risk factor, and then some are just complete accidents. The cell picks up a mutation that allows it to be aggressive and immortal and reproduce. So it really depends on the type of cancer. I mean, there's alcohol related cancers, there's smoking related cancers, there's some that happen in people that are completely healthy. Leukemia, lymphomas are usually a mistake, a genetic mutation that allows them to be, more fit than normal
Mhm.
cells.
Now, what makes you laugh?
So my kids probably, and I laugh at myself. I'm actually not, I'm a person who does a lot, but I'm not good at anything. So I have to laugh at myself. Otherwise, other people would laugh at me. So I laugh before they can laugh at me, which allows me to try things I would never dream of doing. But yeah, I think those are the kind of things that make me laugh is, mainly my kids and what they do. And yeah.
Now, what do you call it? You finished medical school, you started your professional that, and decided, you got married to a physician. What is that like? Two physicians in the house. Are you competitive with him or no?
No, not at all. So we met when I was a resident. No, so I was a fellow and he was a resident, which meant I was senior to him. And he ended up being on my team, which was funny because you work 12-hour shifts 6 days a week together. So you get to know people really well. And it was a very intense rotation.
Mm.
And you know, we just got to know each other as peers, right? And so I had no idea that when he introduced himself to me, I just said, "Yeah, nice to meet you," and went back to typing because I'm focused. I'm not messing around. I'm getting my work done and I'm getting out of there. And then after spending a whole month together, like 6 days, 12 hours, and they were long days, and so we end up eating together. And the joke is he thinks he asked me out, but he didn't really ask me out. He just said, "Are you hungry?" And there's nothing open. It was the cafeteria, right? And so yes, and so when I met him, I was actually dating someone else, and just didn't feel that connection. So I would just be at work, so I could avoid. And the first time my husband, he went out on to dinner. We went to eat with my boyfriend, and I continually got paged to go answer calls for the hospital. So I stepped outside, and he looked at my boyfriend and said, "Well, so who are you?" And he had no idea I had a boyfriend because, as far as I knew, he didn't ask me out on dates. So we were very work focused. We spend a lot of time together just because of the job. And I think that's, you are your true self. And I think that's when you attract the people that are meant to be together. Like you can't pretend you're someone else. You just have to. And I was, I didn't give him the time of day. I had no idea. It was just myself. And in the end of the day, I did notice that we had a connection. And, I just didn't know. As far as I knew, he was just asking me to go eat because this is what you do at, 8 o'clock at night. You haven't eaten all day. And you'll eat with anybody at that point.
And now you're still his superior, right? You're still
No,
his.
so yeah, and back then it was kind of funny, but yeah, he was my resident on my team, but I couldn't do anything. I could be maybe write
w-
up a review, but it is so
w-
it happens in the medical world. There's a lot more doctor-doctor relationships. We never talk about medicine that much, although, if he has a question about hematology, he'll call me. And if I have a question about kidney, he's a nephrologist. If I have a question about kidneys, I'll call him. And the other, we consult each other, but we really don't talk about work at home. And it's interesting. He has zero interest in research and science. He's just a bedside guy who he can tell me every patient he's talked to, he can tell me where they work, where they live, their family members. And I can tell every patient I've talked to what genetic mutation is driving their cancer and all their laboratory data. So we're very different, actually. And even in the way that we practice medicine, which is, unique and kind of funny, but he would rather just not ever do research and just see patients and take care of people, where I'm more like, let's drive science and let's get studies going.
Now, I had my kids older. I was 33, 34 when I had my first child. You probably were that in that. Is that difficult? What do you? Is there's a challenge to that? You
Yeah.
know?
Yeah. So I think that was a big piece of our relationship and a big piece of my life, is that I was super focused, and I met my husband, and I said, I just want to let you know, I don't ever want to have kids. Like, I don't want to have kids. And then I said, and I never want to move to Minnesota, which is where he's from. It's an amazing family. Because I grew up in Arizona, and Minnesota might as well be the, North Pole, because it was
Yes.
just cold. And so, but once you get your career done, you start to think about what's important, what matters. And I kind of knew he wanted to have children. But at that point I was, 35, 36. And I was like, whoa, this isn't something that we can just wait forever. And, we're always saying, like, let's wait till we finish this and that. And he was a year behind me. And so, yeah, I'd been done my training. I was a faculty at the university, and I just said, hey, if we're going to have kids, like, we need to do this sooner than later. And we were really lucky and blessed with getting, having our first kid before I could change my mind, to be honest. So, like, and I was 37 when I had her, and my first child. And so it was challenging, because I was in Salt Lake City, Utah. And I can tell you that the people that taught all my birthing and lactation classes were half my age. And I was the only one, that didn't have children. And I joke, I had a physician assistant who said, you need balance. You need kids. You have to be balanced. You're a workaholic. You need kids. And I said, you're crazy. And so she thinks that she's responsible for the fact that I have children, but I let my husband think that he convinced me that, it just made sense. I mean, you get your goals met, but I did fear the challenge of the balance. And I think that's something that, all working moms struggle with. All working parents struggle with that. And male or female, you want to feel like you're there for your kids, but it's challenging. You have a demanding job. So, but nonetheless, I was blessed to have one daughter right away, and then the second one shortly after. And then I had 5 miscarriages before the last one. So there is definitely some, disadvantage or potential problems, but I didn't even think about it. I just kept trying. And we ended up with our third child, who's a boy, and he's the only grandson in the entire family. So it's kind of unique. Yeah.
I have
So
a boy.
who knows? You never want to. There's multiple other granddaughters. He's the only grandson out of 10
That's
grandkids.
awesome.
Yeah.
Awesome.
So yeah.
Another question. It says, can you see diabetes and heart disease be detected faster through blood tests?
Yeah, I mean, certainly the causes of diabetes, of high sugars, that's definitely a blood test that can be easily done. And then heart disease has, genetic factors, cholesterol, exercise, overweight. A lot of it's not just blood tests. A lot of it's other, clinical risk factors, family history. There can be a family history of heart disease that people can be very healthy about. It's kind of like high cholesterol. You can have a great diet and exercise, but a lot of that's genetic. And sometimes you're just predisposed to have, your family gives you lots of good and lots of bad. And there's a breast cancer gene called BRCA. Most people have heard of this, but some of my female patients, they would joke, my mom gave me big boobs, but my dad gave me breast cancer because of the gene that came down from the father's
Wow.
side.
From
And
the father.
yeah, and it doesn't matter. Your parents give you some things that make you great, and they give you something that can potentially pass things to you that, make you have a risk factor for some sort of genetic disease or just normal disease. So things run through families. That's definitely true. And sometimes there is that predisposition. So, but a lot of the tests can look at, risk factors, but some of them are not just blood tests. They're really how someone's, their family history, their weight, their body mass index, all those things play in.
Question: what age do women need to start getting mammograms?
Yeah, so it's been a little controversial, and there's different professional guidelines. I think that very well that age 40 is one accepted guideline. If you look at some of the oncology professional guidelines, if you look at more of the primary care and task force guidelines, they had pushed it up to 50, but the same thing happened with colon cancer screening. It's now gone down, right? We're starting to see colon rectal cancer in younger people. So you can typically, even if you don't have a family history, you can always ask for screening at age 40. The screening may not be as sensitive, but at least you get a baseline screen done. Most insurances will pay for it, especially if there's any concerns or family history. And then if people have less risks, they can say, well, you don't have to get screened every year. There's a couple different options, and there's different professional guidelines, but your doctor typically will pick the one that fits what the patients want to do and what makes sense.
Now, is low white blood cell count indicative of cancer?
No, not really. There's lots of things that can cause a low white blood cell count, and so it really it's not indicative of cancer at all. Like, it can be so many other things which are more likely than cancer. So definitely has to be looked at and followed up on.
Right. 3 questions from family members that when they heard you're going on the show. If someone did a screening, a body scan, and they said you have an enlarged prostate, is that cancer? Is that dangerous?
It's not, because you can have hypertrophy, which is just normal, normal thickening, which can be not related. You can have no enlargement and have a bad player of cancer, right? So to be honest, PSA is probably one of the most sensitive tests for prostate cancer. And so if you had an imaging scan that suggested that, the prostate wasn't totally normal, and then you had an elevated PSA, those two things in combination would be more alarming. And then a lot of it's age dependent, but you can have an enlarged prostate, and it could be, because it's called benign BPH, benign prostatic hypertrophy, which is just enlargement of the prostate that's completely benign, but very common, right? And so imaging, it's not things that are growing. Things like ultrasound, MRIs, CT scans, it's sometimes different texture or density in the images that give us a clue. Like, ultrasounds are really good for certain things. They do transrectal ultrasounds of the prostate, which are pretty darn accurate. They look at the tissue and say, is it big, or is it big with, some irregular findings? And those are the thing. And blood test PSA is a pretty good screener.
Okay, another question. Someone had breast cancer and they had to take they were coming, you were telling me this on the plane, like they were gonna approve something and they backed off on a pill or something that people take for 5 years, or I don't know.
Yeah,
I
so
don't.
it's a little more complex, but there are 3 major types of breast cancer. There's hormone receptor positive that are kind of driven by estrogen and progesterone. There's ones that are HER2 positive, which are driven by a HER2 growth factor. And then there's triple negative breast cancers, which are more aggressive and aren't driven by hormonal influence. The most common is hormone receptor positive. And so when a woman has a history of estrogen receptor positive or hormone receptor positive breast cancer, one of the insurance policies to keep it from coming back, even though they've had a surgery that removed all the known tissue, or preventing it from happening again, is blocking estrogen. And so a lot of women are prescribed pills that block estrogen that's made not just by the ovaries, it's made by adrenal glands, fat cells. And so they're blocking estrogen at a level that's, completely suppressing. So if I used to say, like, so for example, there's a couple breast cancer cells out there, or some cells that have the potential to turn into cancer, and their growth signals estrogen, you're basically blocking that signal. So that without that signal to growth, they don't ever become breast cancer, or they don't ever progress. And so we probably overtreat people, but if we can keep it from ever coming back or never happening, even preventive, the blocking the estrogen is sort of like putting people into menopause earlier and then making it more of a deeper menopause. But if you can keep breast cancer, a lot of women will sign up for that and they tolerate those medications quite well. Other women don't. So it's kind of a balance of what you can tolerate.
Wow. Okay. Question. I know I'm asking a lot of questions, but people,
That's okay.
how can eye cancer go to your liver? Eye cancer. Is there such thing as an eye cancer?
There is a melanoma called ocular melanoma, which is an eye that tends to spread to the liver, versus skin melanoma, which tends to spread into lymph nodes and other things. So that's probably what that question is referring to, because ocular melanoma is one of those melanomas that's rare, but it almost always goes to the liver, and it's very challenging and hard to treat, mainly because it's rare and aggressive. And so a lot of the times the pathway of where certain tumors spread kind of depends on if they enter the blood stream or into the lymphatic system, and where they tend to like to just sometimes go and can maintain, can set up a place where they're able to grow unchecked. A lot of this has something to do with immunity. You're the host. If your host body can recognize the tumor as abnormal, then there's a host response to this tumor or anything that's invading, right? But a lot of tumors can become, they can suppress the tumor, the host's immune response. They can hide from the immune system. They evade the immune system. And so they're kind of allowed to grow unchecked. And a lot of places where tumors tend to migrate sometimes is the liver. And that's just because of all the blood goes through the liver, and they can, find an environment where they can thrive and grow unchecked. And so that's probably what happens. Some tumors are sort of predisposed to go to different organs.
Wow. Okay. How do you know all this? I mean, you remember all this. Some people
Well,
have to go back and
10 years of training post college, and then 15 years of practice, and you just do this all the time, and you see these questions, and yes, lots of information that you're tested on, and continually using, right? So you don't ask me any questions about taxes or financial stuff, because I will not answer it, or even actually my husband's warned me, don't teach the kids history or geography, because they will they will be lost, and that's probably true.
So, do you have to do tests every few years, right? To keep your
Yeah, you have to
certification.
do continuing medical education, then you have to recertify for your board exam. So after 10 years, which goes by fast, right? You have to sit for the board exams again and pass them, and pay for them and pass them. So yep, board certification, you have to keep that up to date. And then every year you have to do continuing medical education units, which you turn in to maintain your license.
Wow. I had this is interesting. I was asked by Kaiser to teach a class for uh, uh, what do you call him? Kidney, not kidney doctor, the internal physician, internal medicine physician,
Mhm.
about about the Middle East and the latest, the health issues in the Middle East, but do comedy in between. So it was interesting to do that because it was part of their continuing education. But
Yep.
here's a selfish question. My daughter had sepsis, which is an infection of the blood. Back in October, she was in in the ER in the hospital for a few days, and because of her tonsils infections and what do you call it, strep throat. So they gave her Norcos, and they gave her Percocet, and they gave her other medic. Are those stay in your body for a while? Does that become addictive after a while?
Yeah, it's there's difference of a tolerance versus addiction. And so I always had oncology patients that were afraid to take narcotics for cancer pain, because they said, well, it's going to stop working and I'm going to have nothing that works. And so in different, I worked in primary care and the county, like some clinics where people were drug seeking and addicted, and a lot of them didn't have a pain. So a lot of times if you're taking medication for something you don't use, there's a higher potential for addiction. When you're taking it for real pain, it's less likely that you're going to become addicted to it. People do get tolerance to certain things, and then again, it does depend on a little bit on the person and what they're treating, and but pain medicines are important, and so it's a balance, right? It's a balance of just saying, and a lot of those pain medications have side effects. So a lot of my cancer patients wouldn't take their pain medicines when they really needed them. But on the same side, I'd have cancer patients that would pass away and their families would come in and try to fill their pain medicines, because they were drug. And it's challenging when you are balancing that. And I remember when there was stricter prescribing, prescribing rules about narcotics, and I had a terminally ill population. There was days I was writing like 10 OxyContin, breakthrough pain meds, and my patients would, be not even wanting to take them. They were afraid to take them. They wanted to I always used to say, you don't get extra credit for suffering. Like, there was no point to just suffer in pain, and they wanted to be stoic and they were afraid. And it was a totally different world than what we see sometimes with the abuse of drugs. So you can kind of, it's not that hard as a physician to see what pain medicines are being used for and when they're required, and how they're very important. And I used to have to push how important they were, and for treating pain. So, it's a challenge. And I think there's a lot of stigma about narcotics and when people need them and do they want them. And then physicians have a lot of, they are scared to prescribe them. It's a challenge. It's part of medicine that, was not the best part of medicine, but it was reality. We had to deal with it. But when we were even writing prescriptions, there was a duplicate verification of our IDs. They wanted to send messages to our cell phones. It was just kind of crazy. And it was hard for me to get narcotics to my cancer patients sometimes, although, we had friends who had kids that were like getting Norco or Percocet for $200 through a text message in 20 seconds, right? It's a real problem. And I don't know the answer. I just know that physicians can usually tell when pain medicines are being used appropriately and when they're not, and they try to guide that the best they can. But
We're having this problem right now. As this second, my wife is still at the pharmacy parking lot because the physician gave my daughter more Parkinson, and the pharmacist like, no, I can't give you that now because I've already gave her some. But she said, well, she already used them. She takes two every 4 hours. That's what the doctor prescribed. But so you're right. At this, they're very careful about people abusing that. But uh, a question to you now. Some people are asking, "Where's your office?" I know you no longer see patients, but you're more into the scientific, research and all that with Octus, the name of the company, Oncocyte.
Yep.
So what's the latest on cancer fighting? Are we getting better? Are we able to help people better now with the new technologies?
Yeah, so I think that in 2018, immunotherapy drugs were approved. The first one was approved. Since then, there's been over 6 immunotherapies approved. So this is ability to get your immune system to recognize cancer cells. And what we're seeing with that is amazing progress. And so the problem is not everyone has the same amazing result. But if you can get your immune system to take care of the cancer, that's a win-win, right? So that those drugs are approved in multiple tumor types. They've been very successful. They have a different side effect profile, but tolerable, other than they can overstimulate your immune system sometimes. But so the company Matt currently is looking at, really finding the best patients that have an immunotherapy option, because the biomarker or the prediction for that isn't perfect. And so it's more complex than looking at the tumor. We have to look at the tumor and the immune system as a whole and that interaction. And I think that's where progress has been made. Lung cancer, again, used to have a terrible prognosis, but with immunotherapy, it's really all changed along. Melanoma is the same thing. People with metastatic melanoma used to just die, and now they're living, sometimes even cured. And so I remember in practice, one of the melanoma patients I had who had brain mets twice and was told he was going to die like 3 times, got on an immunotherapy trial, and all of his cancer went away. And
Wow.
to the point that he was treated up in Denver, and he was treated by this guy who is just world renowned, first in the field to do some of these studies. And he was like the first patient on one of these clinical trials with this immunotherapy drug. So then I inherited him, and he's a rancher cowboy, and he's an older man. And, at the point we thought after 3 or 4 years, we're like, this is never coming back. Maybe we should take you off these drugs. They're going to cause a problem. And he said, no, never stop him. And so I had to get the blessing from the academic center that maybe he should come off this. And I remember one day I was in the hospital and I saw his name pop up on my list that he was in the hospital. And I looked to see why I was there. And, he was birthing a cow and it broke his leg when it came out. So again, he never wanted to go off to immunotherapy. And he told me, I'm never coming off of it. I need to be on it for 8 years. And he was technically cured. And again, he may die of something completely different. That would never have happened without these, immunotherapy drugs. So I think that's been one major progress in oncology treatment. And that's something the company I'm working at is focused on, defining that a little bit better and making sure that we're using these drugs in the right patients. The other thing is some patients get these drugs. They want these drugs. They saw the commercial of the guy who is totally normal now, but that's the minority of patients. So to give people a drug that's not working is almost as challenging. Of course, you want to move them to something that is going to work. And I think that's where we're at. There are some great treatments for certain people, but they won't all work the same. And it's just defining that and making the right choices or making informed decisions for your patient's treatments rather than just following the list of drugs to use or guidelines. The guidelines have become a lot more flexible. They used to, have two choices. Yeah.
How do you balance your work with your home life as a mom, as a wife, and you have a lot of horses to take care of too?
Yeah. Yeah.
How do you do that?
So part of it's probably I don't sleep, just kidding. But I mean, I really, I've always have a high energy level and I prioritize. This is how you become successful at work. You prioritize things. There's things that I just let go, and I think that's hard to do for certain things. So it's all about priority. What's going to make everyone happy? What's going to be the best for the family? What's going to be the best for my work? And that's one nice thing about having a more flexible job, which was a blessing in disguise, going into, an industry type corporate job where I'm working from home a lot or traveling versus going into the clinic every day. Because what happened for the first 6-7 years of life raising kids is that my husband and I could not be on call together. We never had a weekend off together. I was raising kids by myself. Then I was working in the hospital and he was home with the kids. So it wasn't good, right? We survived it, but it wasn't good. And that's changed where I don't work weekends. And when he's working weekends in the hospital, I'm home with the kids. So I'm home with the kids more. But then that means I have to work at 2 a.m. or 3 a.m, or, I just have to work different hours, but I can work different hours, which not everyone can do. Right. And that's what has made it work. And that's how I balance it. I just work hard when I need to. When I travel for work, I never stop working. Like on the plane, I'm usually that annoying person who pulls out the laptop. And then when we're landing, they're yelling at me to shut the lid and turn it off. And I'm focused. But when I get home, then I can take a deep breath because I worked really hard when I was away from home. And it's just that ability to balance, which I think there's more flexibility for working moms in that way, but it is a lot of pressure on moms.
So how is Kimberly came to know Jesus Christ as her Lord and Savior?
Yeah, so it's I think as a kid, we always were taught, taught about God and Jesus. I went to Awana when I was a kid. I was raised Baptist. I think what was really interesting, we were the only non-Mormons in a very heavily Mormon community. So I started going to LDS church with friends and it was just an interesting thing. But once you get a certain age, you realize, okay, wait, I'm not LDS and technically I'm not going to be married to an LDS. So I need to go back into my own faith and started going back, where you're attending the Baptist church a little bit more. But my sister was more into religion and my sister and I didn't get along very well. So I was sort of like, I'm going to pull away from it a little bit. So that's how it kind of went. It was always instilled in us. And it wasn't until when I went to college and I was very young and people were worried about, what was going to happen. And I just ended up meeting some people that were very Christian and they were older than me. They shepherded me in. This is when my parents were divorced. I'd spend Christmases with them. I'd spend family holidays with them because I just didn't know where. I didn't want to go to my mom's, meet my dad. Just kind of in between. And that was important for me. It really was important for me when I was a young, impressionable person in my young adult life, and always had such great religious, mentors. And there's times when you go to the dark side, and what pulls you out is your faith. And I always, some of my faith was really modeled in the Mormon religion. Those are the people I grew up with. And I think they put family, they put God, they put, their faith front and center. And you can learn from any religion just to have that faith, and how your faith looks is very different at different times. And that's okay. Like, that's totally fine. That's how I learned to I just don't like to be regimented. And if I think something's too strict, it's harder to adapt, right? Hard to make it real for you.
Do you think other physicians look at you as a person of faith, and are they against it? Are they mad? How sometimes they think scientifically, and it's hard to accept faith by faith.
Yeah, I mean, I still think there's a lot of religion. There's a lot of explanations for. I don't think religion and science have to conflict, and I think there are a lot of physicians that are open to that. And I think when you interact with people on such a personal level, through, like, when patients say, can I pray with you? I mean, it's really hard to not have some healthy respect for religion, even if you want to not, even if you're not religious. Like, I think I feel I'm very open to my patients. I have no problem saying, God bless you, I'm praying for you. And I've never had anyone be offended by that, even though I know maybe they're completely, and I just go with it, because again, if someone's going to be deeply offended by that, then usually they won't say much. And I think it's better to make the mistake of, it's better to err on it, just be yourself, and it works out. It works out, and it does open people to share their religion with you. And I think it brings people closer together, and you should never be ashamed of it. I think people just worry too much about saying those simple things, like, and I'm praying for you gets a little bit, people may not see that as religious, but to say, can I pray with you? That's a lot more like, I am a Christian. And some people will say no, and that's fine. But I think just putting yourself out there, you make better connections, and you touch people in a way that, again, they could be complete atheists, but they see that you care about them, and they may not agree with that your religion, but
Right.
it's still very touching, and it's always been well received on my,
Right. Well, man, it's been an hour. I can't believe it. First of all, what are you working on right now? What is you looking forward to that you're working on? Are you
I
writing a
think
book? Are you doing something?
I was in a much larger company. Now I'm in a smaller company, and I'm really, it's a great company where everyone works really hard, and we're really just trying to get, stuff that's in the lab, stuff that's in scientific, knowledge into the patient, into clinics, right? Clinical studies that support the use of tests that will drive the future of medicine. So it's really just getting people access to new tests to decision making. That's really what I'm passionate about. And I'm also very passionate that you don't need to live in a big city. You should get the same care if you're on a farm in Grand Junction, like I am, versus in LA County, right? Because I think that one of the most important things I've learned from one of the physicians I took care of, you never want to leave home. You can have all the money in the world, but when you have cancer and your days are limited, you want to be at home. You want to be with your family. You don't want to be traveling to big cities. You don't want that stress, even if you have all the money in the world. So I think that everyone should get state-of-the-art, cutting-edge technology, trial opportunities in their own town. And so that's always been my passion, which is why I live in a small town. well, Grand Junction's a small town comparatively, right?
Yeah, right. Now, last thing I want to ask, what encouragement can you give to someone who either have cancer, afraid of having cancer, have a loved one who has cancer? Is there's an encouragement you can give to them, doctor?
Yeah, I think it's just never be afraid to ask questions, never be afraid to, state what you want, say, hey, this is what's important to me. People assume, doctors have to assume there's a time crunch. And I think it's very important to just say, here's what's really important to me. Like you can say, I'd rather have time with my family than do all this crazy stuff. I mean, people need to respect those decisions. And I think when people have those conversations, it makes it much better, and admit fears, admit your, and, patients don't want to look like they're weak. So they hide things. I think just speak it freely, and if your physician doesn't listen, there's other physicians that you'll connect with, and that's important. You should have control over what happens as much as you can.
Perfect. Thank you so much for your time. I know you have your kids waiting for you. You're busy. I appreciate your time. That was such an educational podcast. So people will be hearing it again and again. So thank you for your time.
Yeah,
Pleasure
thanks for
knowing
having
you.
me. Yeah,
And yeah, so thank you. And let's stay in touch. All right. Thank you so much
absolutely.
and
Thank
Happy New
you.
Year.
Yeah,
Ha-
take care.
bye bye.
Bye.
All right. And thank you guys so much for watching. Wow, that was educational. If you know someone who, just anyone, they need to watch this podcast. They need to listen to it because really helpful. All right. And at 8:30 p.m. tonight, Pacific time, we're going to be back with the Live with Naz, or an hour of laughter and encouragement for you. So join us on Facebook under Comedian Nazareth. And thank you so much, guys. And we'll see you tonight, and God bless you.